Good evening, everyone. Welcome to a session on eye allergies, prevention and management. Most of us would have felt itchy eyes, watery eyes. Are these allergies? Are they something else? Watery eyes we've discussed in the past as far as dry eyes is also concerned, and you can find that webinar on YouTube as well. So today we are here with Dr. Anahita Kate. And I will introduce her in just a moment. This session on patient awareness and public awareness is being done along with IHOPE, which is Indian Health Outcomes Public Health Economics Research Center, and PatientsEngage. PatientsEngage is an online platform for patients dealing with chronic diseases and their caregivers to share personal experiences, information, and learn from each other as well as from healthcare professionals. We do believe that if you are better informed and you actively take care of your health, you will feel more empowered and you will be able to manage your conditions better and make better choices. IHOPE, as I said, stands for Indian Health Outcomes, Public Health and Economics Research Center. It's an exciting, collaborative and interdisciplinary research center that has been set up with a research grant from Wellcome Trust TBT India Alliance, through collaborations between LV Prasad Eye Institute, IIM Ahmedabad, and IIPH Hyderabad. The focus of this center is data analysis, health economics, clinical and public health research, focused more on eye health. Dr. Anahita Kate, who's our guest today, is an assistant ophthalmologist, cornea and anterior segment services at the Shantilal Shangvi Cornea Institute at LV Prasad Eye Institute. She finished her medical education and postgrad in ophthalmology at JIPMER in Pondicherry, and then did a fellowship from LV Prasad Eye Institute. Her clinical interests include management of ocular surface disorders with a special focus on ocular allergy and immunological keratoconjunctivitis. Reminder to our viewers, as always, the views expressed in this video are of the panelist and are meant for spreading general awareness. They may not reflect those of the platform, and they definitely do not replace a medical consultation. So please consult your doctor for specific medical issues or reach out to Dr. Anahita through the LV Prasad website. You can post your questions. We are live on Facebook, YouTube, here on Zoom, as well as on LinkedIn. So you can post your questions on Facebook and YouTube and Zoom here. You can always reach out to us through our social media channels or our website, www.patientsengage.com. And I'm Aparna Mittal. I'm founder PatientsEngage and the moderator for this session. So let's get started because we have a lot of ground to cover. Welcome, Dr. Anahita. Let us start with, if you can describe what are ocular allergies.
Good evening, everyone. Thank you so much for giving me an opportunity to be a part of such a unique initiative. So to begin with, ocular allergy. So in our body, all of us have immune systems which are responsible for fighting off pathogens. Now, these can be bacteria or viruses. However, in some individuals, instead of mounting this response to a microbe, what happens is that normal antigens that are present in the environment, now this can be pollen or it can be dander, our immune body recognizes these as pathogen and mounts an immune response against them. And that is what constitutes an allergy. And when this develops in the eye, when the patient has a sign or a symptom because of this in the eye, that's when the patient develops ocular allergy.
And typically, I know you've talked of some of the signs and symptoms, but if you can clarify on the typical signs and symptoms that people can expect if they have an allergy.
So allergy in the eye can have a very varied spectrum, but across the board, all the patients will have redness in the eye. They will have watering, and the most specific symptom for allergy is itching, because of which the patient will say, I have this constant urge to rub my eyes. And again, based on how severe the allergy, the patient can also have blurring of vision, and in very severe cases, decreased vision as well. And Overnight, when the patient gets up in the morning, they may complain that they have accumulation of mucoid discharge in the corners of the eyes. That is also very common in ocular allergy.
Okay. And are the symptoms different at different age groups? So, are the symptoms different for babies? Are they symptoms different for children, elderly? So are there different, symptoms?
So symptoms are the same, but what happens is that since this disease affects young individuals, it can start as early as 2 or 3 years of age. It depends on how well the child is able to express. So at that age, they may not be able to tell that they have this grittiness or they have this foreign body sensation. So the complaint that they manifest with is that the parent tells that my child is constantly rubbing their eye, and after that there is a lot of redness, as opposed to an older child or an older adult who, and they themselves will come and tell that I have redness and I have discharge or watering. So the symptoms and signs don't differ. It is just based on how old the child is, how they present with.
Right. And often, especially in India, when there is some level of itchiness or some level of redness, there is a strong tendency to self-medicate or to, go to the local pharmacist. What are the risks associated with doing that?
So, like you very correctly said, there are a lot of medications that are available for the treatment of allergy. But the major issue with self-medication is that any problem in the eye will actually manifest with redness, watering, like you discussed in the webinar that was conducted previously on dry eye. Dry eye also has a lot of symptoms which overlap with allergy, and this is also true for infections. This is also true for raised intraocular pressure. So all these patients will have some amount of redness, some amount of pain, grittiness, or discharge. It is very difficult to tell externally what exactly it is that you have, whether it is an infection or whether it is an allergy. And so it is, we do not recommend and we strongly discourage self-medicating in any eye problem which has redness.
So can you describe, you've used grittiness. Can you explain grittiness? Because not everybody will know what you refer to when you say grittiness.
Yes, so grittiness, typically what the patient says is that I have this feeling that there is mud in my eyes. When I blink, I can feel like there is a foreign body that is constantly rubbing. And there is no foreign body per se, but it is just the inflammation in the eye because of the allergy. That is what causes the sensation that there is something in the eye.
Right. And, once you go see a ophthalmologist, and I guess you also want to highlight that people should see an ophthalmologist and not an optometrist. But if they go and see an ophthalmologist, what is the diagnosis process that will typically happen to ascertain that it's an allergy?
So as of now, most of the allergy testing is limited to systemic allergy. What is there in ocular allergy is still being looked into in terms of research. So the diagnosis will be predominantly clinical. The ophthalmologist will have a look at your eye under a slit lamp, the machine that we use to examine the eye. And based on the signs that are there, we will decide if this is an allergy or just a non-specific congestion of the eye or redness of the eye.
Okay. And once it's been ascertained that it is an allergy, what is the typical, management protocol that is suggested?
Okay. So like I was telling earlier, allergy can have a spectrum. There are some forms, and a majority of the allergy fits into this category, which is basically mild allergy. So the patient can have allergy in during one season of the year or a couple of seasons, and then it resolves. And when the season comes again, that's when the patient has that allergy again. And or the patient can have a mild allergy which comes on and off throughout the year. So there are some periods where the patient is symptomatic and some periods where the patient isn't, and then it again recurs after a couple of months. So at the first visit, we try to ascertain what type of allergy it is that you have. And based on that, the patient is typically given some topical medications, some eye drops, and you will be asked to review back based on how severe the disease is. Now, what is important to understand is like, unlike say an infection or a conjunctivitis of the eye, this is not something that will get, there is no cure. So eventually you are, or most of the patients, a significant proportion of the patients will have a recurrence, will have a relapse. It does not mean that the primary treatment did not work. It is just the nature of the disease. So every time you have a relapse, you should not get alarmed. You should always go back, consult your ophthalmologist, and they will restart you on the medications that are required. Now, in this, like I said, this is a huge subset of patients, but in a smaller subset of patients, a smaller fraction of patients who have allergic conjunctivitis, they may have a very severe disease, and so they will require something called as topical corticosteroids, and this will require more frequent follow-ups, and it is very important that the patient complies to this. So now what happens is that most of the time, since the individuals who are affected, they are very young children, we are actually handling the parents, and they tend to be very apprehensive, and very rightly so, because their child keeps coming with recurrent episodes of redness, and they're very tempted to use these topical corticosteroids because they have instant relief with these medications. And so we strongly discourage the patients, the parents, from doing this, and understand that this is basically a chronic disease and requires frequent follow-ups.
Right. And if it is mild, will it, does it go away on its own ever, or it will always require treatment?
So what we typically tell the patients is that, based on when they present to us, say the patient presents as 5 or 6 years, usually once the child crosses puberty and completes that phase, the disease limits by itself. And this happens again in most of the patients. There's a very small fraction who continue to have the disease beyond, say, 20, 25 years of age, but this is again extremely rare. For most of the patients, they may have a few cycles and then it self-resolves.
Right, right. And you talked of the allergies being seasonal. Are there again specific seasons in an Indian context that we see where these allergies play up more, because we don't have the typical, spring and pollen, or pollen enduring spring kind of, not in all cities anyway. So, how do you determine how the seasonality affects people?
So typically, we see two crops of seasons where the incidence of allergy rises. And this is mainly, there is a little bit of spike in the winter seasons, but a majority of the patients present to us during summer. And we also explain to the parents that when they come, say, somewhere in September, October, that, when it becomes March, April, May, your child is definitely, or is very likely, going to have recurrence of the allergy during this symptom. And when they are mentally prepared for it, the reaction to the episode when it does happen is much better. But yeah, these are the seasons in India, the summer season, or rather the switch from spring to summer in these months.
And does monsoon play a role in terms of allergies in an Indian context?
So not so much. I mean, we do see allergies even during the monsoon seasons, wherever that happens, but it is not as frequent or as severe as it is during the summer.
Okay. And what are the common allergens that we would see both in metro cities as well as indoor, outdoor, metro, non-metro?
So again, with respect to allergens, in the context of ocular allergy, this is not very clearly understood. It is more understood in terms of systemic allergy. And the major problem in India is that there is a lot of variation in the geography. Therefore, a lot of variation in the pollen, in the plants, even in the insects that are present in our house. But by and large, indoor allergens, the most common ones are dust mites. We have animal dander, basically the epithelium from our household pets, and of course mold from fungus. And when it comes to environmental or external allergens, the most common ones are grass or wheat pollen. But again, there is a lot of variation from north, south, east, and west. And even they say every 200 kilometers, the pollen changes. So we have to be aware of the geographical area that we are residing in before ascribing a particular allergen to a patient.
Right. And can the allergies lead to infections, or do infections and allergies coexist? What are the scenarios you see?
Like I said, a majority of patients, they have mild to moderate allergy, and in these conditions, infections are not common. However, in the very severe allergy, what can happen is that it makes the surface of the eye very vulnerable. So even the normal bacteria which are residing over the surface, they can infect these vulnerable areas and lead to a secondary infection. But commonly, infection is not coexistent with allergy.
Just a reminder to those of you who are watching, we are talking to Dr. Anahita Kate on ocular or eye allergies. So if you have a question, you can post it on Zoom or on the social media channels. We are live on Facebook and YouTube and LinkedIn. So there are, we talked of various types of treatments. You talked of the severe cases needing corticosteroids. But there are also sometimes a lot of over-the-counter eye drops that are available. Are these okay to be used without consultation? And if so, how do you determine? And if not, why not?
So once again, we strongly discourage the use of over-the-counter medications. And the primary reason for this is, like I said, it is very difficult without a complete examination to understand whether this is allergy or not. And most of the over-the-counter medication contains steroids, even when it is with an antibiotic. So usually an antibiotic steroid eye drop or an ointment is given. And if it is not allergy, then the steroid is going to exacerbate whatever the underlying problem is. If it is an infection, it is going to worsen it. If the pressure is elevated, it is again going to increase that as well. That is number one. The other thing is, even if you are correct about the fact that this is allergy and you treat it with over-the-counter steroids, steroids are not safe at all. They by themselves can result in a lot of complications which are very difficult to manage down the line. The first and the most important one is that, like I said, it increases the intraocular pressure, and this causes permanent damage to the nerve in the eye. And because a lot of these individuals are young children and young adults, they have to live with the consequences of these side effects for 4-5 decades minimum.
Right.
And it becomes very difficult to handle.
Right. So, you said steroids are dangerous, which also leads people to avoid, steroid treatment, and then they will try all kinds of treatments rather than start their child on steroid. So, there are people who will try alternative treatments. We've heard of even things like ghee and oil. We've also heard of other medications that may be available. Is there any data on safety of any of these, or efficacy, or usefulness of any of these?
No, unfortunately, we don't have any data on the safety or efficacy on any of these. But like I said, the allergy causes the surface of the eye to become very vulnerable, and instilling these homemade remedies, the primary concern there is that it is not sterile. So we have a risk of again inducing a secondary infection in the eye because of the installation of these remedies. So we do not recommend the use of this as, say, a quick remedy in case of an acute exacerbation or something like that, just until we get to the doctor. Even that we don't recommend.
And for a lot of eye conditions, like even dry eyes, with one type of dry eyes, you can do fomentation, etc. So is fomentation something that fomentation is essentially for the users? It's just putting, warm cloth or a moist warm cloth over your eyes. So, is that helpful? Is that harmful? What is the?
In allergy, what we actually recommend is to use cool compresses. So water from the fridge, take a clean kerchief or a clean cloth and place it over the eye. Especially in children, this not only to a certain degree reduces the inflammation, but also prevents rubbing of the eye by the child. So prevention of eye rubbing and counseling of parents regarding this is very important, because although it is a symptom of allergy, it also causes progression of allergy. So it is like a vicious cycle. And as long as the child continues to rub the eye, the disease will continue to progress irrespective of any medication that we give. And one of the most important measures that we tell the parent, because the parent will always want to know how do we stop the child from rubbing the eye, is to use a cool compress. And it provides that momentary relief and stops the child from rubbing the eye.
Okay, that's great. Yeah. So yeah, that was my other question. How do you help a child prevent the eye rubbing? And you're saying cool compresses are the best way. There are also these I mean, you can make cool compresses at home, as you said, just take cold water and a kerchief or something. But sometimes you get these cool compresses in the market. Do they work as well, or
Yes.
They do?
Yeah, so anything that decreases the temperature, irrespective of how that is achieved, will help in improving the symptomatology in the immediate acute phase.
Okay. I know we've got one question, but we'll come to that question after we finish a couple more. So are some people more vulnerable to ocular allergies or eye allergies?
Yes. Although there are a few individuals who are genetically predisposed, they have a predilection to develop allergy. So basically, what happens is that these allergens which are present in the atmosphere, most of us don't have a reaction to it, but some of us tend to develop an allergy to them. And this is even more evident in those patients who have ocular allergy and a concomitant systemic allergy. So this can be either asthma or it can be dermatitis. So in these patients, they are more prone to have the more severe variants of ocular allergy, or even the moderate allergy, they will have more frequent relapse. And so they require more treatment as compared to a patient who just has a mild ocular allergy.
So you brought up an interesting point. So if somebody has say an asthma flare up at the same time as a ocular allergy flare up, is there a common treatment that typically gets done, or they will both need to be treated separately, and the family must take the child to both specialists simultaneously, not simultaneously, but one together to see both specialists?
Yes, I think that's a very interesting question, because we very frequently see such patients who are consulting to doctors, and sometimes the involved parties are not aware, because they fail to understand. The parents may not realize that one thing is connected to the other. So in terms of treatment, whenever we feel that there is a concomitant allergy, instead of treating with eye medications, we may just directly allow the systemic allergy therapy to take care of the eye, because it is the same therapy, it is just given in a different form. So the child may end up getting a double dose, one from the eye and one from the body. So most of the times the systemic treatment is sufficient, but that brings us to, like you asked, is it sufficient to just get a consultation from one of the doctors? No, because what happens is that because of the chronic allergy, whether it is in the body or whether it is in the eye, the patient may develop sequelae, and understanding if these sequelae are setting in and whether they require a separate therapy by themselves, that is a call that has to be taken by that specific doctor. So you have to consult both, but taking one common treatment may suffice.
So it is very important for patients and their families to, when they're talking to the individual doctors, describe the symptoms holistically, so that, and if they're already in touch with somebody for asthma or somebody for dermatitis, then they need to let the ophthalmologist know that as well.
Yes, that's very true.
Okay. So is there anything that as an individual we can do, or a child we can do, to help our child protect our eyes from these allergy causing agents?
So The problem with this is to identify what is the allergen that is responsible, and that is very difficult in a country as diverse as ours, both in terms of our geography, the socioeconomic environment that the patient comes from. But once an allergen is identified, there are ways of avoiding. Like, for example, if it is a dust mite, then what we recommend is to wash all the linen in the house, the curtains more frequently, and not just wash them with normal water, but with very hot water. That is what kills these mites. So if you feel that your child has an allergy that goes beyond what, say, the child has had it for a couple of years, or the child has very frequent relapses within a year, it is recommended that you consult an ocular allergist, an ocular allergy specialist, so that these tests are carried out. Like I said earlier, typically in a normal case of allergy, we do not carry out any specific tests for the allergy per se. It is predominantly a clinical diagnosis. But in these rare cases, it is better to undergo these tests so that we understand what are the allergens and how to avoid them. For example, if it is to a pet, then better to avoid take the pet to another place. Sometimes it is to certain food substances, and we need to avoid the food in our daily diet. But taking this extra step is, we recommend this to parents who have children who have more than the moderate allergy.
And is pollution also, just received that question, is pollution also an allergen?
So pollution per se, maybe not, but it carries the pollen, which can be an allergen. So this is a predominant reason why some individuals get allergy in one season but don't get in another season, because the pollen is different in different seasons. So during the pollination season, if it is a city which is more polluted, then the air is not going to flow very easily. The pollen is just going to remain there. So you may have an exacerbation longer than you expected in those days.
Right.
Very
So
similar to asthma.
Right. Okay. So there's a question, I don't know if you can see it, doctor, but I'll read out. This is from a scleroderma patient, also has Sjogren's along with keratoconus. Facing severe allergy since the last 1 year. I get severe itching, which then results into super sticky discharge, which gets stuck in the eye. And becomes painful. I've been told I have allergic conjunctivitis. This keeps happening on and off, and I can't use my scleral lens due to this. What can I do?
Okay, thank you for that question. So we first need to understand whether the allergy is truly an allergy or whether it is a reaction to the scleral lenses. So contact lenses very frequently induce a reaction in the eye, which is allergy, but it is allergy to the contact lens. So simply by avoiding the contact lens, if the symptoms are coming down, then it is likely because of the contact lens. However, if they persist even after, say, there are 2-3 weeks that you have not worn the lens, but you still have the symptoms, then you probably do have allergic conjunctivitis. Now, FML again is a steroid. It will provide quick and rapid relief, but the moment you stop the steroid, the effect is going to wash away. And in such conditions, we have topical medications which do the same work of the steroids, but they do not have any of the side effects of the steroids. So again, I recommend that you consult a specialist who looks at these conditions, and they will be able to start you on these medications. These medications are available topically as eye drops and eye ointments, and the oral versions are also available. So you probably require them.
So what you're suggesting is that in addition to seeing their rheumatologist or immunologist that they would be seeing for Sjogren's or scleroderma, they should also see an ophthalmologist.
For the Sjogren's, they're probably consulting an ophthalmologist.
Right.
So they can probably bring this up that, they are very dependent on steroids, and maybe they can switch them over to steroid sparing immunosuppressants.
Okay. I hope your question was answered, AK. So one question is, can ocular allergy lead to temporary or permanent loss of vision?
So, like I said, there is a small fraction of patients who develop the severe form of allergy, and these patients can develop sequelae because of this. Like the question that was brought up, a very common sequelae of ocular allergy is keratoconus. This is basically when, because of the chronic eye rubbing, the shape of the cornea changes. It is typically spherical, it starts becoming conical. And this affects vision, and it can be progressive and cause other complications because of this. Other than this, it can also affect the stem cells. It can also cause infection. And because of that, there can be scarring and permanent drop in vision. So, one of the things that parents have to be vigilant about, and like I said, they are very apprehensive. So what they do is, every time the child has an acute episode, they take the child to a new doctor, thinking that the previous regimen did not work. And every time a new doctor sees, they start the patient fresh, because that is what we have to do. We cannot directly start the patient with high-end medications. So the child again receives a course of topical steroids, which may not, first is that it will cause complications, and second is it may not be sufficient to control the inflammation. But we have to go through that stepwise process to understand whether it is sufficient or not. So you are going back and you're resetting the process every time you consult a new doctor. So to stop this from happening, it is a good idea to stick to one person, and so that when one therapy has not worked, that person will know that, this is not working, and they can switch over to the next course of therapy. Like the patient was just telling that she is not comfortable with steroids, she will require the next medication in the line of therapy. But if they go to a new person, they will again start with steroids, because for all of us, steroids are the first line of therapy in allergic conjunctivitis.
So just taking that example, if the patient was to go and tell the next ophthalmologist that I have tried steroids, as she said, I've tried it for a month, it gave me relief, but it didn't kind of go beyond that. So even then you're saying an ophthalmologist will start with that steroid all over again, or it's dependent on what the patient has communicated with the new doctor?
So sometimes we see signs which are indicative of the fact that the patient has had this disease for a very long time. But what happens is that all of these other medications that I've been telling that also work the same way that steroids do, they have a latent phase in which from the start of or like, for example, if we give the medication today, the effect of the medication will set in only 6 to 8 weeks from today. So in that period, we still have to give the patient steroids. Otherwise, that acute exacerbation will not get controlled. And typically what happens is that when the patient goes to another doctor, they stop all these medications. So that period that they have waited, they again have to go through that latent phase again. Which is why they have to again anyway start the steroids, because these medications, the effect doesn't set in immediately.
Right. So in case for any reason, right, a patient needs to change a doctor, could be that they are moving cities or, whatever reason, when is the right time to make the switch?
So this is, if the switch has to be made, it is definitely not going to be determined by the allergy per se. But what is important is that you get a good referral letter from the doctor who has been treating you, so that the next doctor understands that these were the things that worked for you and these were the things that didn't. And they don't have to go through that trial and error method all over again. And you can just start off where the previous doctor left. That would be a better idea.
Right. Yeah, I mean, I think that really would be the better option, except that often patients don't think doctors will be comfortable in giving that referral letter. So, so that is sometimes an issue. I'm just doing a quick check on any other questions. I know we are on time. So you talked of cool compress, and you talked of not using alternative medications or therapies. You've already covered, allergy causing agents, and we've talked of how best to manage this, as a parent or as a person with. I know you said that in most cases it's self-limiting, and after you get to about 24, 25, you will probably not. Most people will not have allergies, but do you see that those who have things like chronic asthma or dermatitis that continues into adulthood, then those people are more likely to also have allergies, ocular allergies?
So not only those patients, but even patients who have just ocular allergy, a few of them can continue to have the disease into adulthood. And we are also seeing patients who are now developing an ocular allergy de novo in adulthood for the first time as an adult. So this allergy tends to be more severe, unlike the allergy in childhood, which is self-limiting, where we tell under 10-15 years and it's going to go away. This allergy does not go away. The possibility, again, like I said, in the childhood allergy, a majority of the patients have very mild disease, maybe once a couple of every other year, and then it resolves with medications. That doesn't happen in adult allergy. It tends to be more severe. And again, the rate of or the risk that you will develop a complication is you're more likely to develop a complication if you have allergy as an adult when compared to allergy in childhood.
Right, right. But the treatment protocol follows much the same.
Very similar, yes.
Okay. Thank you. Any final words or message to our audience?
So the first thing that I would like to re-emphasize is, as tempting as it may sound, especially for those patients who know what they're dealing with, the patients who have had an attack the second, third time, please refrain from getting over-the-counter medications, because there is no way for you to monitor what that medication is causing inside the eye. And although it may be difficult, especially for those who have a chronic disease with very frequent relapses, it is not easy, every now and then to go to the doctor, wait over there and get a medication that you're going to get anyways. So I understand that is difficult, but please do that, because there are a lot of other things that we are constantly checking before giving the medication. And also we are looking out for things that can also happen in conjunction with the allergy, whether you're developing any changes in the shape of your cornea, whether this is becoming a sequelae, whether we need to ramp up the therapy, whether we need to ramp it down. So all these considerations, we factor them in when we are prescribing these medications. So absolutely, if there's one point that I want everybody to take away is, do not use over-the-counter medications. And the second one for parents is that if there is one thing, everybody asks, what is it that we can do? So although avoiding allergens is something that we are not very certain how to go about it as of now for ocular allergy, the one thing that you can do is to stop the child from rubbing the eye. That itself will contribute a great way in helping or preventing the progression of the disease and preventing the formation of sequelae that can result in blindness.
Right. Thank you. Thank you so much, Dr. Anahita Kate. I think you explained the topic, the risks associated, and what people need to do both for themselves, but especially as parents of young children. And, that is often it's much more stressful and difficult to manage. So I think you touched on that very well. And I think it is important for all of us to recognize that while, these are specific drugs, so it's better not to use over-the-counter medications. It's better not to just refill the last prescription, but to go and see the doctor and make sure that, they are ascertaining whether you need the same medication or a different medication. So thank you so much, Dr. Anahita, and for all of you who are watching, thank you for joining us. And if you have any further questions, you can always write into us on our social media channels. And once again, we thank IHOPE and LV Prasad for supporting this initiative.
Thank you so much for letting me be a part of this. It was a wonderful experience.
Thank you. Thank you so much.